Hello, my name is Kalpesh Patel. I'm an assistant professor of medicine at the Baylor College of Medicine here in Houston, Texas. I'd like to thank Gastrointestinal Endoscopy for inviting me to discuss our recent publication titled Impact of CAP-Assisted Colonoscopy on the Learning Curve in Quality in Colonoscopy, a randomized trial that we performed here at our institution. So the concept behind this study started a few years ago in my own practice while I was teaching first year GI fellows, and it seemed like there was a lot of pressure to teach fellows effectively in a short period of time. One, just based on the clinical constraints of everyday practice, and two, the limited opportunities some of our fellows would get in our program. So the overall theory behind this study was what steps could we take to maximize the initial experience of the first year fellow while they're learning colonoscopy. Certainly we could add aids such as simulators. We could train our endoscopists to train in a formatted way. And these were interventions that have been shown to be effective. We were looking for a more consistent and easy to add approach. I had heard previously that in other areas, in the initial training of colonoscopy, many practitioners use the attachment of a distal cap to the end of the colonoscope. The theory there being that it provides a little plain room for the novice endoscopist to guide the scope without having excess time spent pinned against the colonic wall and aiding in navigating turns and so on. So based on hearing that, we designed a study to see if the addition of a cap during the initial training experience in novice fellows would maximize the effort or maximize the experience in the first few months of fellowship. Our goal really was to assess the procedure, meaning how did a colonoscopy performed with a cap by a novice endoscopist compared to a standard procedure without the cap. And so our study design was a little different, which I'll talk to you about. So we began this study by identifying three novice endoscopists who were beginning their GI fellowship, and we at one site. We then didn't randomize the fellows, but rather randomized the patients to undergo a procedure with the fellow using a scope with a cap versus procedures without the cap. Our primary endpoints were to assess independent cecal intubation rate, meaning how often did the fellow reach the cecum without hands-on assistance from the faculty. And our secondary endpoints included cecal intubation time, both overall with and without assistance. And we also measured or used the ACE assessment tool to measure cognitive and technical factors during the colonoscopy. And finally, we introduced traditional quality markers as well, including adenoma detection rate, cecal intubation rate, in order to see if we could detect any differences in these important markers. The study began in July of 2016, and the first 200 consecutive patients undergoing, for the most part, screening exams were randomized in the study. Three first-year fellows participated in the study. The data was collected over a 3-month period during that time. Our results, as detailed in the paper, showed some interesting things. Our first primary outcome showed that in those procedures taken as a group where a novice fellow performed the colonoscopy with a distal cap attached, there was a significant difference in the frequency of reaching the cecum independently, and that was done in a significantly decreased amount of time. Furthermore, when we looked at ACE scores, both the cognitive and technical aspects, fellows performed better based on that tool in those procedures that were performed with the addition of the cap. We did also look at secondary outcomes, including the quality measures, which did not show a significant difference. In order to assess these beyond just comparing means, we employed the use of cum-sum learning curves. If you're not familiar with these are curves that can monitor progress during a training period. Based on expected outcomes, we set a threshold for competency in performing colonoscopy. And what we detected in our study was procedures that are performed with the cap attached as a whole approached competency as performed by the fellow at a faster rate than those performed without a cap. Even during just a 3-month period, one of the individual fellows, in fact, met the criteria for competency themselves when using the scope with the distal cap attached. So what do we make of these results? I think our study shows that the use of a distal cap, which is a relatively simple and inexpensive tool, may make the initial training during colonoscopy higher yield, especially when we are crunched for time or teaching opportunities. This may make the most of each individual opportunity and allow our novice fellows to become or approach competency more quickly. In addition, this may free up more time for the accumulation of more advanced skills in endoscopy as our field as a whole moves towards more and more complex therapeutic procedures. Looking forward, I think we would look forward to have our results validated in larger groups of trainees and perhaps in other types of settings. I'm very excited about these findings, and I look forward to discussing these with you in the future. Thank you.